Buenas tardes, bienvenidos
Good
a todos.
afternoon and welcome, ladies and gentlemen, to our webinar, a Hearts webinar, which is an integrative clinical tool. And we would like to now begin our event in a couple of minutes. We'd like for you to follow our instructions. Remember that this webinar is being broadcast in Spanish, Portuguese, and English. You can select the language of your choice just by going down to the lower right-hand corner of the screen. The globe icon will have the language of your choice. So we're going to have the also the audio, the background audio, and you can just post your comments on the chat. But any questions for the speakers need to be posted in the Q&A box, which is also located in the lower left-hand side of your screen. I would like to remind our technical team, our interpreters, and our panelists to please turn your microphones on when not being used. I now offer the floor to Dr. Pedro Ordúñez, who is our star presenter for Hearts. He would like to now begin with a few words of welcome. Thank you very much, and thanks to the colleagues, Jenny. I'd like to welcome you to the third of our series of Hearts presentations, a special, actually, our publication on the Pan American Health has now celebrated its 100th anniversary, and we have Hearts of the Americas, which is another publication. So this is the third Hearts webinar, and I'd like to warmly welcome everyone. This is a very exciting webinar as we begin to see all of our participants who are joining in. I would just like to mention that we are broadcasting through Zoom, but those colleagues of yours who have not joined in might be interested in coming in, because the first 500 who join in will receive a certificate of participation. That's for the first 500 participants who join the Hearts webinar. So you're going to be able to follow not only our webinars, for those that are perhaps cannot get it through the Zoom, you can also get it through WhatsApp. So we'd like to again welcome through YouTube. We would like to welcome you to the third installment of the Hearts webinar. Today we're covering a very important topic, and that is how we can use clinical tools such as Heart, which is, of course, an integrative, highly useful tool. The program is actually going to be divided into two segments. First, we have Dr. Vasquez, who is the editor of the Pan American Health Journal. And in this segment, we're going to have panelists who have not been with us before. They're just now joining us in the Heart events. I would also like to present later on Dr. Carmen Antini, and Jenny Rodriguez is going to be with us during the first segment of this webinar. The second segment is devoted to the Heart Initiative, to other articles in this special issue, and we have Maria Guadalupe and Casales from Mexico, and we also have participants from Peru attending, and then our star keynote speaker, special guest, who will conclude the presentations, is Dr. Robert Donald de Petit. So without further ado, I would like to now introduce our presenters. We have Damian Vasquez, editor of the Pan American Public Health Journal, going to be discussing Hearts in the Americas. Just if you could just relate to us exactly how things are going with the various consultation processes underway. Thank you very much. And if could we please make sure that my presentation is in presentation mode? Yes, it is. Thank you. I'm not going to focus specifically on hearts in the Americas or hypertension because we have experts present who know a lot more about it. But what I would like to comment on is the context in which the scientific information can become or can translate into health response and measures. So we now are celebrating our 100th anniversary of uninterrupted service with the Pan American Journal of Public Health. And we see that our 100 years of publication are really a landmark. And if you go to our website, you will see much more information about our 100-year journey. So overall, I would say that the mission of the magazine, of the publication, is to transform what we see on the left into what we see on the right. There are some obvious changes. However, I think that what's more evident here is not really what's most important. It's obvious that a manuscript is a text that has not been reviewed, whereas a scientific paper has been reviewed, subject to peer reviews, and even when it's been subject to peer reviews, it may still have some setbacks, but it's still a quality comment. The manuscript is not edited. Scientific papers are edited with a special layout and color coding. However, a manuscript is simply a document that has been shared between authors and the staff of the scientific journal. No one else really knows about the existence of the article or its content, whereas a published scientific paper is available to a wide variety of members within the community, including the academic community, healthcare professionals, decision makers, and it's available to the public at large. Therefore, I think that if the information presented is adequate, and the measures, appropriate measures are taken, then we have a virtuous cycle take place because researchers and the authors from the scientific community can use this article in order to generate new bodies of research. And that's how science has progressed since time immemorial. We have seen the building of blocks of knowledge that we heard about perhaps yesterday, and yet today we've seen new modifications and change. We can also see changes with new techniques, new parameters. In the case of high blood pressure, it may include improved devices and also new treatment parameters. Decision makers at the same time can formulate new public health policies that will lead to new changes within the community. And then finally, the general public becomes more aware from these scientific papers. Sometimes it's through an intermediate step because it could be through the media itself. People start to take charge of their health and they begin to change their lifestyles. And in the best case scenarios, they begin to take on more healthy lifestyles. So to not bore you with details, I would just like to mention that we have this website that is devoted to this, and we're going to show you a video as to how to access the content. Right now, we have 33 articles that address many different subjects and also offshoots relating to cardiovascular disease in various countries. So we have 33 articles that, and we continue to add to the content. For example, down at the lower right-hand corner, we have several articles that are in orange. One was published yesterday and two earlier in November, and we still have one more article to be included. I'm not going to show you all the metrics of the 33 articles because that would bore you, but the articles that we're going to discuss today on, for example, diabetes and hypertension, also one article on Peru's political will in this area, and also the Mexican initiatives. These are articles that have been downloaded more than 1,300 times. So we're very pleased to learn about this because these were just published very recently, and they've already been well received through our website. And we don't know exactly we know that we have other channels of dissemination that can be added to this mix. And now to conclude, I just wanted to add that the publications really are a team. Publishing is a team effort. And I forgot to really cover and discuss exactly how many people are behind the scenes in preparing this. Any article of this nature usually has an average of 5 authors. It's been subject to reviews by 3 reviewers, 2 editors involved. And then you have, of course, a typesetter that has done the layout. Then you have 2 librarians on average participate in uploading the databases and archiving this. Then you have 5 indexers who've contributed to disseminate this broadly, in addition to the editorial team and an administrative staff member. So we have a total of 23 people on average that are involved in this effort. So if you multiply that by hundreds of articles, we're talking about hundreds at a minimum, hundreds of people involved behind the scenes. In addition, you have donors, partners, the editorial committee, and institutions involved. So I'd like to thank all of our staff and all of you who have joined us in this webinar. So now we're going to show you a very brief video where you'll see exactly how to access the supplement. You can do it either through your PC or even a mobile, an iPhone. Thank you.
Muchas gracias, Damián. Adelante la producción.
Thank you, Damián. And now let's show the video.
Uy, alguien se nos quedó ahí dormido, ¿no?
I think somebody's asleep at the switch.
Bueno, muchísimas gracias al doctor Damián Vázquez.
I'd like to thank Dr. Damián Vázquez for that presentation and reminding us about the usefulness and the benefits in the scientific journals. This is really the only way to quickly replicate a lot of the body of knowledge that we receive, new advances in the Americas, some of the results. So look up the special edition of the Pan American Journal of Public Health. You can again consult that. Since we have a fairly broad audience, we're actually coming up to almost 400 participants, and it looks like the YouTube channel is also functioning pretty well. I'd like to send greetings and welcome to our colleagues. We have colleagues from the BBI in Mexico. We also have participants from Peru, Argentina, Bolivia, Dominican Republic, Cuba, from Guatemala, Brazil. But we also have people from countries that are not within hearts. I know that Uruguay is about to confirm. And we also have people from Paraguay, Puerto Rico, We also have people from Mississippi, Texas, and other areas in the United States who are listening to the Hearts of the Americas webinar. So we're really looking at Hearts is now being listened to very closely, not just in the Americas, but within many jurisdictions in the United States of America. Now, I know that in Chile we have several people who are also listening in, but we see as part of the CIPFAM from various regions, and that's where Heart has a real priority role. In other words, bringing people from primary healthcare centers throughout the region who can leverage these opportunities and advantages. So I'd like to also mention some other colleagues who I see in the chat, but from messages. But now let's begin with our first panelist, who's going to be addressing one of the topics for today. Dr. David, who is a assistant professor and healthcare researcher from the University of Michigan, who is very familiar with the region. He knows Guatemala like the back of his hand and other parts of Central America, or he is addressing a highly relevant topic, and that is how to integrate hypertension and diabetes, two very prevalent priorities and concerns. So it's a pleasure to introduce Professor David Flood, who is one of the key authors of this article, one of the main authors that was just published in the Pan American Journal of Public Health. Go ahead, David. The floor is yours.
Okay, great. Can I just confirm that my screen is sharing okay?
Everything okay. Go ahead, please.
Okay, gracias. Hi, everyone. It's such a pleasure to be speaking with you today. David Flood here. I work as an assistant professor at the University of Michigan, but my heart is in Guatemala, and I'm also an associate investigator at INCAP, the Institute of Nutrition of Central America and Panama. And this week is very important for us because we are helping with the initial implementation of Hearts in Guatemala. In fact, just this week, some of my colleagues are doing the first training with our colleagues and collaborators from PAHO, Ingrid Garcia. I don't know if she's here. So very, very, very exciting. And I'm excited to talk to you today about the role of diabetes in integrated clinical management of diabetes and hypertension as part of the Hearts framework. So it's truly a pleasure to be with you today, and I thank Dr. Vasquez for giving my team the opportunity to publish this special report in the recent special issue of the Pan American Journal of Public Health, specifically focused on the, pragmatic suggestions for integrating diabetes into the heart hypertension framework. And that's what I'd like to talk to you briefly about today. So I'm sure, as most of you are aware, if you've been to any of the prior seminars as part of the Hearts in America series, that the World Health Organization has really spearheaded the Global Hearts Initiative to reduce the burden of cardiovascular disease worldwide. And as part of this initiative, as Dr. Ordonez says, the Hearts or Hearts in the Americas framework is the clinical package to really try to get evidence-based clinical interventions into primary healthcare facilities to try to reduce the burden of CVD. Again, with an emphasis at the primary care level. Hearts in the Americas, as you all know, is the regional implementation of the Global Hearts. And as part of this, there's also what's known as the Hearts D module, which is a module published in 2020, which focused on the diagnosis and management of type 2 diabetes. And I'll come back to that in just a moment. So many of you might be familiar with some of the large epidemiological studies, such as the PURE study, which have really shown that most cases of cardiovascular disease, both incident cases and deaths, are attributable to a small number of modifiable risk factors. And to date, many Hearts implementation projects have been focused strongly on hypertension. It's the leading modifiable risk factor for cardiovascular disease and can be treated very cost effectively. This graphic comes from the Global Burden of Disease. And it shows that in 2019, high systolic blood pressure is still the #1 leading modifiable risk factor for all-cause death. But here you can see that high fasting plasma glucose is also an incredibly important risk factor. And together they account for about 1/3 of the population attributable percentage of all deaths in the region. And so this is over 2 million deaths per year in the region. I know many people on this call will be clinicians and be very familiar, but just to review briefly, this is a figure we present in a special report, but as many of you will know, hypertension and diabetes have a lot of overlapping risk factors, and they lead to common pathways of complications. And so elevated glucose and blood pressure can give rise to macular vascular disease in the form of ischemic heart disease or stroke. And it can also predispose individuals to this microvascular disease pathway in the form of kidney disease, neuropathy, limb amputation, and vision loss from retinopathy. And in fact, the burden of kidney disease in the region from diabetes is extremely, extremely high. And so evidence-based clinical management of hypertension and diabetes addresses some of these shared risk factors, both through pharmacological and non-pharmacological interventions to control blood glucose, blood sugar, or blood pressure, and also lipids. This brings me to hearts. So many of you will be familiar with hearts. And as I mentioned before, there exists a hearts D module that is very, very, it's excellent and focuses a lot on the clinical diabetes recommendations and how they can be implemented into hearts. For the purposes of our special report on the integrated management of diabetes and hypertension within hearts, we wanted to give some more pragmatic advice or implementation strategies for how we can structure the integrated management of hearts at the primary care level. Pragmatic policies, clinical structures, measurement techniques, going beyond the guidelines to present some practical tools, because I think that's what hearts has been really so influential at in the case of hypertension. So in our special report, we go into a number of suggestions and ideas, but I wanted to just highlight a few of them for you here before I move on. So first, the H module in heart stands for lifestyle or healthy lifestyle counseling. And as all of you know, lifestyle counseling on diet, physical activity is really a foundational element of hypertension, and perhaps even more so for diabetes. Diabetes self-management, education, and support is really a foundational pillar of all good diabetes care. So in our special report, we talk a little bit more about how within the hearts framework, we can really try to scale up the intensity and the scope of disease-based self-management. For example, some tools that might work to increase intensity but keep down costs might be group-based formats, team-based care, the use of peers, or even community health workers. The next example I wanted to just briefly talk about was the hearts module and evidence-based protocols. This has been a really revolutionary module, in my opinion, in terms of hearts fostering simple, standardized protocols for the management of hypertension. And I think there might be a role for considering doing this more to a greater extent in the realm of diabetes. Especially creating protocols that nurses and nursing assistants can titrate under the supervision of physicians to try to reduce the population of patients with very poor glycemic control. And one final example within the hearts framework that I wanted to draw your attention to is this third module, the access to essential medicines and technologies, or the A module. I think a really important challenge with respect to diabetes compared to hypertension is the greater need for laboratory equipment, consumables, insulin, and cold chains in the case of diabetes. And I think an integrated heart framework needs to think especially strongly about making sure that those materials and supplies are available consistently at primary healthcare facilities. Finally, as many of you will be aware, a couple of new classes of diabetes medications, the SGLT2 inhibitors and the GLP-1 agonists, are excellent at reducing cardiovascular risk among people with diabetes. They're still quite expensive often, but I think the hearts framework is an excellent place to start to try to think about mechanisms to incorporate these medicines into formularies as prices permit and as we can get them on the ground. So just to wrap up, the key points that I wanted to convey, my team and I wanted to convey from this special report are first that in the region, there's a significant and really overwhelming burden of hypertension and diabetes, and that much of the strategies for management overlap. Second, that there's really critical opportunities for the integration of diabetes management within the revolutionary hearts hypertension framework that Dr. Ordunez and the rest of the team have really put forward. And finally, that diabetes treatment must not only focus on hyperglycemia or reducing blood glucose, but really also on these CVD risk factors like hypertension and dyslipidemia that are really critical pillars of diabetes management as well. So with that, I want to thank you all for your attention, and I look forward to participating in the rest of the webinar today.
Excelente, excelente, doctor David Flo. Yo quiero invitar a los
Dr.
panelistas.
David Flood, that was excellent. I would like to invite our panelists who are going to be accompanying David in this first segment. David, you can leave your camera on. I would also like to invite Carmen Antini and Jenny Rodriguez. You're going to be in between two women here. And we have Carmen Antini, who is the PAHO, the diabetes advisor. So she's very well versed in the subject. And then we also have the other participant, Jenny Rodriguez, who is the architect of the HEARTS webinars. She's going to be discussing the implementation of HEARTS. How can this become a practical tool for people in general? So I'd like to welcome a few other participants here as we, first of all, I'd like to welcome, well, first of all, you know who's listening, David? There's somebody who I really admire, Professor Oscar Diaz. He's the most renowned physician expert in diabetes from Cuba. He has been an advisor to PAHO for many years from Havana. So he's devoted many years to this. And he said, I wanted to see David Flood because some of the articles, some of the most interesting articles in this supplement are include David Flood's. So I'm going to now introduce Carmen Antini, a PAHO advisor. What do you think about the contents of David's presentation? And what are some of the opportunities that we have to integrate both of these factors? Go ahead, Carmen. Well, first of all, I would like to thank you for the opportunity of inviting me to participate. I truly believe that conducting these types of seminars where we integrate diabetes and hypertension is really a sign, it's proof of what can be achieved. In all of my discussions, I always state that we have people before us who have more than one disease. If we only focus on one, we're not going to achieve the expected results. So the article that you're presenting here, I think, is very valuable. And I'm so appreciative that you have done that. Carmen, then the other question that that comes to mind, it says that heart represents an excellent opportunity for combining diabetes and hypertension priorities. Maybe you can address some of the reasons why. Well, obviously, most of the population, they basically go to primary healthcare facilities. That's where most people go. So that's, I think, the burden of healthcare is focused in primary healthcare facilities. But we also need to be more closely linked emotionally with our patients. So the possibility of being successful therapeutically increase. In addition to that, if we look at secondary and third level medical care is much more difficult for many people. It's harder to get. So we have to focus our efforts mainly in primary healthcare facilities.
So one of the things we're doing at Heart, we want to be as practical as possible in this new environment of building an academic, not just building an academic building, but also to put science to the service of practice and practice at the service of people. So we have produced a tool called Heart Application. And one of the articles that we have right now, which, well, you'll be able to see a lot of things. I'm not going to tell you now. So Jenny Rodriguez is going to present an article. Jenny, what's it all about? Now, the technical team is going to put up a video and we'll turn off our cameras.
Despite the case of remarkable progress, cardiovascular disease remains the leading disease burden in the region of the Americas, accounting for 1/3 of all deaths and producing substantial adverse economic and social impacts. This article introduces a new improved application, the main component of which is the calculator for cardiovascular risk and hypertension management. The cardiovascular disease crisis is consistent with the high prevalence of its main risk factors at population level. More than 60% of people in the region are overweight or obese. 20% have high blood pressure. On average, 9 grams of salt are consumed per day. 80% have raised blood glucose, and 50% use tobacco. Poor control of cardiovascular disease risk factors results from a lack of awareness among individuals of their risk status. Therefore, healthcare providers are essential to identifying risk level as a means of detecting those at high risk of cardiovascular disease and identifying who could benefit from treatment for hypertension, diabetes, and dyslipidemia. Hearts in the Americas transformed the 2019 cardiovascular risk charts developed by the World Health Organization into an online electronic calculator, updating the previous 2014 CardioCal app. After the user enters the requested data, the risk calculator quantifies the 10-year cardiovascular risk for myocardial infarction, stroke, and death from cardiovascular disease, with color-coded risk categories ranging from green to dark red. It incorporates the specific standardized hypertension treatment protocols defined by Ministry of Health in the countries implementing HEART. For countries that have not yet adopted protocols, it includes a generic protocol. How can the tool be optimized in clinical practice? The Heart Cardiovascular Disease Risk Calculator provides a reliable and accurate estimate of risk using easy-to-obtain demographic and biometric data. It is simple to use, provides an estimate quickly, as well as clear recommendations that are appropriate for the individual and the care setting where it is being used. Training to use this tool is simple and quick. The optimal use of the HEART app also involves applying it to high-risk individuals, such as people aged 40 to 74 years with known cardiovascular disease, diabetes, or chronic kidney disease. In such cases, the tool's value is to enhance treatment guidance about managing risk factors based on the individual risk profile. For example, the HEART app may recommend a lower treatment target for blood pressure and more frequent follow-up for high-risk individuals. Additionally, people with known cardiovascular disease may be advised to consider aspirin and statins therapy, or the healthcare provider may seek input from a specialist. The HEART app aims to help individuals and health professionals to improve their understanding of cardiovascular disease risk and the relevance of detecting and addressing modifiable risk factors, and to support proven interventions that are part of the health strategies implemented in most countries. It is a powerful clinical tool that can help to improve the effectiveness and efficiency of interventions and improve the quality of care in primary care settings. Accordingly, the HEART app is an essential step in the journey toward reducing preventable cardiovascular disease in the region of the Americas.
Muy bien, Jenny, muy bien. Le pido entonces a David de nuevo,
Thank you,
a
Jenny.
Carmen
I'm gonna ask David
y a Jenny que salgan de nuevo
Carmen
las cámaras y vamos a comentar un poco lo que está pasando aquí, ¿no?
to
¿Verdad?
turn the cameras
Jenny,
back on. Let's
¿cuántas
talk a little
personas
bit
están
about what's
utilizando
happening here. How
ahora la
many people, Jenny, are
calculadora de
using
riesgo
this
cardiovascular que
cardiovascular
hemos
disease
producido
risk
en la...
calculator that was produced in the Americas? Currently, we have 127,000 people using this app. I just created a slide to show you the data. Can you see it?
Vamos a ir rápidamente Voy a tratar de pasar esto de manera muy rápida.
I'm going to
Sabemos
go
que
through this very quickly. We know that cardiovascular diseases is the main cause of death, according to the most recent data from the World Health Organization for 2021. 17.9 million lives each year were lost to cardiovascular diseases. Now, this tells us what the likelihood of an individual developing a cardiovascular event that could lead to that person's death would be in a given period of time. Now, it's very important for healthcare providers to be able to assess risk and to make quick decisions about clinical treatment, and this is going to bring a benefit regarding controlling cardiovascular disease to the benefit of patients. Now, I would like to quickly say that this cardiovascular risk calculator is more than just a simple calculator, but it is an application that is currently soon to undergo an update. Different things will be added. Specific protocols for diabetes will be added. ACV, myocardial infarction. And so it's very interactive and free, intuitive, and it is evidence-based. Now, as far as data from its use, more than 176,000 users have joined, and you can see a breakdown of data by country: Colombia, Mexico, Ecuador, Argentina, Brazil, Chile, and Peru. Now, I know the rest of the countries will want to chime in, so I'm not going to spend much time, but I will say this has been a very useful tool to estimate cardiovascular disease risk, and each year, almost 6.5 million people benefited from this. With the users that we have estimated cardiovascular conditions in up to 6 million people. Now, to very briefly and quickly show you the calculator, you can access this through your computer or on your smartphone. And this, from the clinical practical standpoint, this is what you can do. You choose your country, your language, and you have the option of specifying whether the patient has or does not have a history of a cardiovascular disease. If the patient has diabetes, then we know that that's someone who's going to have a high cardiovascular risk, and that there are things that can be done, such as taking aspirin or statins. And a non-diabetic person who has a lower risk is also considered here. However, the person may have to be referred to a specialist. Now, a diabetic patient, the cardiovascular risk assessment is done, whether the person knows or doesn't know overall cholesterol levels, and based on that, a host of therapeutical recommendations are made in keeping with protocols made in the country, or established in the country. Now, this is going to be outdated because countries are developing their own clinical input to this. That'll be explained later. It's very versatile. You can estimate risk levels. A diabetic patient, 70 years old, Afro-descendant, with a creatine level of 1.6, and this will tell you that this person, it tells you, it estimates what the ocular pressure is, and then the specialist then that sees the patient will be able to do a more thorough assessment. What we want to show you is that this tool is easy to use, it's intuitive, very practical, and it can be downloaded for free. Thank you, Jenny. So the question we have to ask ourselves now, because sometimes this happens to us, why aren't more people using this? I think this is such an important topic. There are so people who could benefit from a tool like this, given all the recommendations that it offers. Let's go back to David. David, your article is very specific regarding certain interventions that can be made or that are recommended. We know that a patient with diabetes, the first cause of death would be cardiovascular disease for someone with diabetes. So what recommendations, concrete recommendations, cannot be overlooked that people who, that the patient, primary health care, needs to keep in mind with that person has diabetes? Thank you. I'll speak in Spanish. I think a very important topic is that managing hypertension is also treatment for diabetes, as well as treatment with statins to address lipids. And so the multi-factor management of this is very important. We should not only focus on hemoglobin or glucose. It has to be a more comprehensive, holistic approach.
Quería decir, vean el artículo, vuelvan al artículo.
Now, take a look at that article. Go back to the article. You have to control glucose levels, lipids, pressure, and to prevent this way cardiovascular diseases. Carmen, I go back to you with the last question of this panel. What does Bajo have that's new on diabetes? I know that the diabetes outlook was published recently. Please. Thank you. Yes, without doubt, I do understand that was a day in which we celebrated our Day of Diabetes. We launched the Outlook of Diabetes document, Outlook for the Americas, which is currently only in English. It's going to be available in Spanish soon. It's a document that sums up the epidemiological situation. It also looks at essential aspects such as complications, comorbidities, cardiovascular diseases being one of those comorbidities, and a big challenge in our region, the relationship between diabetes and COVID-19, and also with tuberculosis is another important aspect in our region, also as it refers to indigenous persons. And so the first document that we have of reference that's specific for the region is significant. It is a huge effort, and it is the foundation of the upcoming documents we want to publish. I hope this has been like an appetizer for everyone listening in. And when we are going to focus on interventions that are cost-effective and more practical to reduce the huge mortality morbidity burden associated with these two conditions in this region, which is burdensome, onerous. And so I thank David, Jenny, and Carmen for this first segment dedicated to integrating hypertension and diabetes and other conditions, because we're talking about cardiovascular risk factors. But lucky for us, we have a second block that's going to take a closer look at that topic. Now, there are some questions in the chat. So we're talking about the first level attention, which is the door into the healthcare system. But this type of disease calls for ongoing care, which may require greater levels of specialization as the patient, to the extent that the patient has a greater degree of complexity in his or her condition. And so the doctor has the capacity to identify quickly the risk profile. And so the three speakers, I thank you. Take a look at this article. There are two articles, rather, that we are putting up in the chat box right now that you should take a look at. And we're going to move immediately into the second segment of this webinar. I thank the panelists. Now, the second segment of this webinar, we are going to start by presenting. Well, I understand that there's going to be an active pause, a tutorial video, on the use of the calculator. The new guide of hypertension of WHO 2021 establishes different frameworks
Bueno, colegas, seguimos en este segundo segmento. Sigo saludando a un grupo de países que nos están
For the
acompañando.
next panel, we have a team from Porto Alegre in Brazil that is doing a great job under the direction of Sheila Martin in Brazil, in the city of Porto Alegre, for the Ministry of Health of Uruguay also. And I'd like to greet Luis and the team of the Health Ministry of Uruguay that has just joined HEART. Vicky Collard is in South Carolina. I'd like to say hello to you. Our cousins in the US, who also held a great webinar yesterday. I invite you to join this. Now we have a panelist, Dr. Andres Rosende, an Argentinian cardiologist. He was the director of the National Cardiovascular Health Department at the Ministry of Health in Argentina. He is the main author of an article that has to do with the checklist. The HEART clinical pathway. So he has served your presentation on a silver platter because the module now of HEART is a revolutionary one. It has to do with that, by that I mean it's a standardized algorithm. Now, why do we have to go down the clinical pathway of HEART if we have this automated algorithm? It might even be more revolutionary. So, Andres, please. Thank you, Pedro. I'm going to start by sharing my screen.
Muy bien.
Modo de presentación, por favor.
Ahí vamos.
Presentation, please. Here we go.
Muy bien. Bueno, como comentaba el doctor Pedro Ordóñez,
As Dr. Pedro Ordóñez was saying, we're going to talk about the HEART clinical pathway and about an article that's recently published, which talks about the developments that we've carried out in collaboration with countries with which to create this very important product, which brings together cardiovascular disease care and primary health care. Why do we need the clinical pathway, and why do we need that in the HEARTS initiative? Hypertension is not only the most prevalent risk factor, the one of the greatest impact, but the traditional model of providing care is exhausted. And you can see that in this chart. There are huge coverage gaps, gaps in access to treatment, and also big gaps in the quality of this treatment, which is translates into the fact that fewer than 20% of people with high blood pressure actually keep their blood pressure down with to the target level. So you see a great disparity between men and women and across countries of the region. And that's not because we don't have evidence. In fact, high blood pressure is something for which there is a lot of evidence, and nearly 600,000 articles have been written on this. When you type hypertension into PubMed's search tool, we have clinical practice guides on hypertension. Many articles are here as well. Perhaps this is the healthcare condition that has, for which more clinical guidelines have been drafted. There are many with many recommendations with very complex algorithms with different paths, different courses of action, which offer different approaches at the same level, fragmenting the provision of healthcare services, fragmenting to the point, the ridiculous point of uh, that care which is offered being broken down into many different subgroups, sometimes including interesting or worthwhile approaches, such as this chart for combining medicines. But in practice, in clinical practice, it's very difficult to remember all of these different combinations of medicines. So Hearts, from its outset, has been working on transforming and translating these clinical practice guidelines into protocols. This can't be done overnight, of course, and that's why we have implemented a methodology, a step-by-step methodology for us to first obtain a protocol for possible treatment, and then to go to an improved protocol, an acceptable one, and then to work on obtaining the necessary resources to end up with the best protocol, the preferred protocol. So most of the countries of the region, if not all, have gone from these protocols to linear ones that are direct, simple, defining high blood pressure drugs to be taken, specific doses for these medicines, and other types of care. But among countries, there's the genuine concern that while hypertension is of concern, we can't overlook other conditions. That's why in 2021, after 20 years, the World Health Organization's guide for high blood pressure was born. And this guidebook, unlike others that existed in literature, is focused more on implementation with a very rigorous methodology, and it is focused mostly on addressing the main gaps to ensure proper diagnosis and control of hypertension. Combined, it calls for, from the outset, a combined therapy. It builds in cardiovascular risk, the cardiovascular risk outlook, as we've heard from prior speakers. Not so much to say who is going to be treated or not, but what the control target is to be for those who do receive this therapy according to the cardiovascular risk that person has, as well as other comorbidities. And also, it makes a recommendation or a statement of how important the World Health Organization considers it to be to have such a standardized protocol treatment that makes it possible or medication to be offered by healthcare professionals that aren't doctors. I'm talking about pharmacists, nurses, because when you have 50% of the adult population being affected by this, there aren't going to be enough specialists to address them. Doctors and other specialists are too few for that many patients. Now, the drivers for controlling high blood pressure is another document from Lancet that is in our supplement. It's in Spanish and Portuguese. I would invite you to download it because it calls for 8 very concrete actions to be taken if one wants to successfully rein in high blood pressure with a quality focus on quality. Now, there's an article on it's a checklist. In the clinical setting, we take these tools to ascertain cardiovascular risk factors and the different drivers to control high blood pressure. And so there are 34 different questions in this checklist and 3 different categories, which we have transformed into an Excel chart, which gives you a score per category and a total score. This to help countries in their own assessment of their existing protocols, helping them to transition toward a clinical guidelines that would be preferable. Now, here's the current one. A few years back, we moved to a more pared down, direct, simple protocol. And now the preferred one in the heart's clinical pathway, which is the fundamental tool that's a integral part of this initiative because it includes all these different instruments. It's important for the healthcare team, for whoever designs healthcare policy, for anyone who purchases medicines, and it is also important for the patient and the patient's family because it becomes part of the patient's treatment, includes the patient in his or her own treatment, enabling the patient to understand what the therapeutic pathway he or she needs to go down, and it's participatory. And it also enables the patient to demand his or her rights.
So this is really the ABC of cardiovascular care, because these steps encompass all of the strategies of the initiative. Step A identifies the specific conditions where you need to take blood pressure. Step B, you have the cardiovascular risk calculations, combining this with other tools already identified by Jenny. Then step C, we have the treatment protocols, how we incorporate this and updating them with the most recent recommendations from the WHO, recent new guidelines, including the control and treatment objectives based on risks, as well as the accompanying therapies, looking at, and of course, this varies based on the presence of cardiovascular disease. And then in the standardized protocols for treatment, we include the various measures, incorporating pharmacological measures with the non-pharmacological measures and lifestyle changes, given that we have saying that there are 2 potential treatments is a fallacy that has now really just become outdated, because lifestyle changes are not enough to control adequately hypertension. Now, with medications without other accompanying measures that include improved lifestyle changes by itself, that's just not enough either. So that's why you need to integrate these components. We need to standardize the pathway for therapy that is 4 steps so that you can achieve the first milestone where you have a maximum of 3 hypertension drugs, including follow-up intervals, specific intervals that are clearly defined, and some of the drivers for improving quality that includes the repeated measurement of blood pressure readings. So here we have one example and explains why we're talking about long-term medications only to be applied once a day. We would hope to have these in one single capsule in order to simplify the treatment and have a more positive impact in terms of adherence levels. But this should not be a barrier for successful clinical steps. And we know that countries have been able to combine with the medications they already have available as they update their national guidelines and establish processes in order to achieve and incorporate better medicines. And here with the baseline, we have a standard case management of patients, controlling high blood pressure according to their specific parameters and context, addressing at least 3 months of treatment and increase integration, not just as was commented by Dr. David Flood, incorporating diabetes in this, but also kidney disease in managing cardiovascular disease, and also incorporating immunizations, and that understanding that the relationship between non-communicable diseases and communicable diseases is very close. And the most recent COVID pandemic, I think, has very clearly shown this. So what we hope to achieve with hearts is that by 2025, clinical pathway will become standard in terms of controlling adequately hypertension and integrate cardiovascular disease in the primary healthcare arena. So just to give you an example, and many of you who are seeing this webinar are probably have seen this, and these are the efforts undertaken by countries in taking ownership of these instruments and determining their own clinical pathways in the area of cardiovascular health and integrating cardiovascular disease in this. Thank you. I lost the cursor. Here we go. So thank you very much, Andres, Rosende. And now let me welcome some of the other panelists. Dr. Dejanco, who is from the Ministry of Health in Peru on non-communicable diseases, and also Maria Guadalupe Casares, who is a specialist in the prevention and control of diseases in Mexico. So we'd like to warmly welcome you, Maria Guadalupe Casares, and Jorge. Jorge, Hearts is in Peru, and it's making a lot of progress in Peru. In fact, you have been at the helm of this initiative in Peru. So why is it that in one of the articles in this supplement, and you're one of the main authors, it states that the political will and governance are essential elements in the successful implementation of Hearts in Peru? Maybe what more can you tell us about this? Good afternoon. Thank you, Dr. Ordóñez. This basically reflects the experiences, the Hearts experiences in Peru, based on an approach where that public health cannot be divorced from public policies. When the process began in Peru, there were actually culminated in specific moments where we had a change in government administration, political changes. These were people that were deciding the public policies that included ministers of health and various advisors, and the technical team that work in the non-communicable diseases office. And if you add to this that fact that PAHO had invited Peru to develop the Hearts Initiative there. So the ministry, as well as the Office of Non-Communicable Diseases, with the efforts being undertaken in preparing documents and And here, as Dr. Rosende mentioned, clinical treatment. These were, of course, very encompassing, broad documents, difficult to implement, and they required some modifications. So we had the content, we had the guidelines, but what was missing was the process of translating it into a more easily absorbed content and digestible content. So the political will arose when the decision makers in the ministry and the senior authorities in the ministries also took on this program as their own, and they aligned it with the process of hypertension treatment and control. So I think that, as I said in the article, that confluence of political decision makers, not just the maximum authorities, but also at the ministry and sub-minister level, and the advisors that play a key role in the line offices and ministries working with the health minister. They played a key role at that point because the advisors established that link and enabled the launching of the process, the HEARTS process in Peru. And the Ministry of Health played a guiding role, a leadership role. And of course, you also have the various provincial authorities that reflect that. And at the operational level, it's also the priorities are also going to be reflected. So we have that vertical and also horizontal structure that progressively has enabled, with 35 initial healthcare establishments, and then later 234 in 2021 and over 500 in 2022. So we've seen a progressive escalation. So in the article, we're trying to show that a political will cannot be absent or divorced from these initiatives. Governance plays a key role. And I think this is another key consideration. Those external participants also play a key role when we see decisions being made at the highest policy-making decision level. So the academic community also played a key role here. Universities, some of the major universities took on a key role, and they brought together all these sectors from in other words, the ministers, the advisors, technical staff at the ministry, as well as the members of the academic community, including the deans of the schools. So we believe, in the article states that it is vital to create that space where each and every sector can come together and work towards this objective. As I said, both the political decision makers and those involved in the implementation of the policies, they must be closely aligned with this initiative. Well, I think, yeah, you covered just about all of the bases. Vivian Perez, our advisor in Peru, indicated that there's that symbiosis between the office of PAHO country office accompanying the ministries of health, but under the leadership of the Ministry of Health. So they started with 34 healthcare centers, and today they have over 500. So countries that are not making that same progress at that same speed need to ask, what happened in Peru? How did they achieve this? How could they affect this change so quickly? So with that, thank you very much. Now let's continue with Maria Guadalupe Casales from Mexico. We know that in her country, the initiative has also grown significantly. One of the authors of the article, who talks about the preliminary results in Mexico, but I think you're showing the path forward. So, what is the importance of the use of indicators and monitoring follow-up mechanisms for programs like this? We have programs, initiatives, and we have a major event where we raise the flag, we celebrate, and then when the money runs out for the project, then what? So, what is the status of this and how important is the data and all of these statistics? Well, first of all, thank you, Pedro, and I'd like to thank the whole team for kindly inviting me to participate. Thank you, Andres. Excellent presentation that you gave. Of course, it's important because you have to measure. You have to know exactly how we're doing and how far we've advanced. So you need to have evaluations, and these are undertaken through the use of indicators where we can determine just how well are we doing. How well is the strategy being implemented? Is it really meeting the expected goals? And it also helps us to determine whether the interventions are effective or not. I think that's the crux of the matter. Not just implement measures, but also be able to determine how much progress has been made, how effective, and also measure in specific timelines to identify what meaningful changes take place. Obviously, participating with the primary healthcare team so that we can reinforce all of their skills and competencies so that we can achieve the expected results. At the clinical level, the monitoring process also provides us information about the performance level of the equipment and teams, and that way we can continuously improve quality. We should never lose sight of the fact that our end state is to improve healthcare for patients. And it's important then to measure in order to be able to determine whether significant and meaningful changes are taking place within our patient population and in the community. So when you visit some of these healthcare centers and you measure results, tell us a little bit about that. What are the factors that have really contributed to significant change? Well, I think it's important to also motivate them, motivation for change, to identify the nursing staff, tell them that they can carry out more effective actions beyond their daily duties, to be able to measure cardiovascular readings. Look, that's another role in nursing, to make sure that the nursing staff can get a better understanding that the response is also in their hands in improving patient outcomes, to look at and compare what the situation was like before, when patients were suffering from chronic health issues, and now where we have many new tests, and after 6 months of our study, we are now providing, and it's important that they see that we now have daily evaluations, patient and nursing notes and follow-ups. So for the personnel and healthcare personnel, it's essential to see exactly how much progress they've made, how they're doing. And I think all of these statistics will motivate them and will keep them moving in that direction. Excellent, excellent. And the fact, I always say this, I know we're running out of time, but I would just like to welcome, as we just take a pause, I'd like to welcome Dr. Miguel Arquette from the the School of Medicine at the University of Uruguay in Montevideo. About a week ago, we were asking, where is the evidence? What are the evidence of things that are doing or going successfully? Well, just look at the Pan American Journal of Public Health, and you'll see many examples of countries presenting indicators as well as clinical pathways. Also, I ask you to visit our website and the chat. I know that the TART team is now providing a great deal of references and information about articles. We're adding a lot of reference information in our chat box. Also, I'd like to welcome Barone, who works in the also the diabetes realm. So how we have so many people from many different jurisdictions that want to continue driving these changes in addressing chronic diseases and also cardiovascular disease treatment. And I just wanted to also mention, we had a press briefing at PAHO, headed by the director of PAHO, and mention was made of that during this season, we're seeing a significant increase in respiratory disease. COVID has not really disappeared. And now we're seeing influenza, and this is something that was raised by the acting director. And also we're seeing a large number of cases of respiratory disease that is really overwhelming many healthcare centers. What is a solution that we have? Because clinical pathways for hearts includes recommendations, immunization recommendations, and we're not just doing that for nothing. So, Andres, why is it so important for the clinical pathways for hearts? Go ahead. Thank you, Pedro. As you clearly indicated, the vaccine outlook is, we don't include it in the clinical pathway for nothing. We know that vaccines are effective not for preventing disease, but for preventing the complications that these diseases may bring. We have those with diabetes, with hypertension, those that have suffered from heart attacks, those that have had strokes, those that have complications as a result of these diseases like influenza, COVID, pneumonia. They also face a greater risk of facing a new coronary event, as well as strokes. And vaccines have consistently shown not only do they reduce the respiratory complications because of viral disease, but also they reduce the recurrence of coronary events and cardiovascular disease events. So we need to convey that idea that vaccines are one additional cardiovascular preventive measure. That needs to be, we need to hit home that. Well, thank you very much. And I ask the team that you please post the link on the chat. If you didn't see it, please take a look at it. There's the director's press conference that was held yesterday talking about the risks that we're facing currently. And once again, those with patients that have cardiovascular disease, and that basically includes all of us, because the magnitude of the challenge is overwhelming. There's nothing more daunting than the scope of the cardiovascular diseases in the region. So we need to have sound implementation, instruments for implementation, more than just the program. So we have the clinical pathway on the one hand, we have the support instruments in terms of clinical management that are going to guide the implementation. To have that clinical support and the political support is going to be decisive, because without those two things, even if we have the pathways, the protocols, and the instruments, nothing will happen. And Maria Guadalupe, we have to know where we're going. We have to measure exactly how much progress we made, as you have already said, Maria Guadalupe. I see that the director's press conference has already been posted on the link. And again, we need to reinforce the healthcare in both communicable and non-communicable diseases. And now we're going to move on to our keynote speaker.
Pausa activa, adelante por favor, producción. Ignacio.
Go ahead, Ignacio.
Uy, me quedé sin retorno. Alguien me dice, tenemos pausa activa ahora y teníamos, a ver, ahora parece que
I think now we have, yes, he is sharing the screen.
Muchísimas gracias.
Thank you very much to our production staff. Remember, we have the Hearts app that is going to summarize all of the content. But now we're going to put the crowning touch on this webinar, a webinar that has been so important. And we have Professor Donald Di Petti, a distinguished academic from the University of South Carolina, also has attended the Columbia University, and he's one of our star, in this case, our star keynote speaker. We'd like to get your advice, someone with so much experience. What needs to be emphasized in the future with the Hearts program? Go ahead, sir.
Well, Pedro, thank you and the audience very much for having me. I'll ask Jenny if she will bring up the slide set. We only have a few slides, but I do want to share with you some closing thoughts.
Yeah, just give me a second, please.
Uy, 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 ¿qué nos pasó? Bueno, pero van a estar. Tomen paciencia. Adelante.
Just give me a second.
Yeah. Tenemos al profesor Di Petti que seguramente nos va a dar
We
ahora
have
los consejos.
Professor Donald Di Petti. What can we discern from what we have been discussing? There's so much information. What can we distill from all of this and convey as a key message? How do we conclude this whole thing? Go ahead, Professor.
Well, thank you very much, Pedro. Sorry for the interruption, and I thank Jenny for bringing up these few slides. So, Jenny, if you could have the next slide. Pedro, what I heard listening over the last hour, 30 minutes or so, was I heard two common themes, if you will, that are now layering on and actually embellishing the Hearts program to a significant extent. And those two thoughts I heard was in the concept and in the spirit of clinical integration. And they were, number one, the importance of cardiovascular risk assessment and its implications on clinical decision-making. It was not, what I heard was not to assess cardiovascular risk just for the sake of assessing it, but there are very valid clinical reasons why we should assess risk when we are capable, and I will get to that. And the second thing, of course, I heard from Dr. Flood was that we should really strongly be considering, and not only strongly, we should and must start integrating hypertension and diabetes care because they are so interlinked. Next slide, Jenny. Well, let's start with the cardiovascular risk assessment. And the question is always why. It's not just because or because we can, or because it's because we should. And the reason we should assess cardiovascular risk assessment is for many, many reasons, but I just show four that are right immediately available to us. And we heard some of it already today. Number one, cardiovascular risk assessment should be recognized in the overall health assessment of the individual in our examining room. And of course, even at a population level. But more importantly, cardiovascular risk assessment, as we're going to see, has implications regarding when you start pharmacologic treatment. What blood pressure threshold are you going to use? If you're going to start antihypertensive pharmacologic treatment, when are you going to stop? What is the target? And cardiovascular risk assessment is integral in determining those targets in subsets of individuals. And finally, even in our patients with diabetes, there are some guidelines that recommend risk assessment and decision-making on risk assessment regarding intensity of our pharmacologic therapeutic agents. In this case, it would be the statins. Well, let's just look at blood pressure first. Next slide. I was very privileged to be on the WHO guideline committee that led to the recent pharmacological treatment guidelines in adults with hypertension, as you've already heard. Many of our panelists and speakers already allude to. This right now is the very first recommendation from the WHO guidelines, and it's what blood pressure threshold should we initiate pharmacologic treatment? And as you can see, there were 3 subsets in terms of what individual is in front of us, and we're discussing in that individual examining room, if you will. And if you go right to the bottom, cardiovascular risk is integral in the pharmacologic blood pressure treatment threshold, if you will, if you're high cardiovascular risk. In individuals that do not have cardiovascular disease, but are at high cardiovascular risk by risk assessment, in addition to clinical assessment, such as diabetes, chronic kidney disease, et cetera, the threshold blood pressure is different. In all hypertensives together, it would be a systolic blood pressure of greater than 140 or greater to start pharmacologic treatment. But in individuals with high cardiovascular risk by risk assessment, it's a systolic blood pressure of 130 to 139, an important clinical difference. Next slide. Well, this also translates to the target or the blood pressure level that you're going to stop with, and that's going to be on this next slide. If the threshold's going to differ per cardiovascular risk, then the target is almost certainly going to differ as well, and that's also the case in those individuals with high cardiovascular risk. The blood pressure is to achieve a systolic blood pressure of less than 130 systolic. In all the others without known existing disease or diabetes or CKD, it's 140 to start and to reduce the blood pressure to less than 140 to stop. Yenny, if we could have the next slide. And finally, in the WHO guidelines, there's one recommendation that is specific for cardiovascular risk assessment. And that goes as follows. We should be assessing cardiovascular risk in all individuals, and particularly in all individuals with the initial diagnosis of hypertension. But there's a caveat, and the caveat is only when it does not, the risk assessment does not interfere with initiating pharmacological therapy. And that's an important consideration, and we deliberated regarding that for quite a while, if you will. Yes, assess risk, but do not let it interfere with initiation of pharmacologic therapy when the initial diagnosis of hypertension is made. And then let's turn to the second area, and Dr. Flood has already eloquently discussed this, and that is the integration of hypertension and diabetes. It's always puzzled me having that we have had the knowledge for 2, maybe even 3 decades now, that hypertension and diabetes is married at the hip, if you will, in terms of its integrated pathophysiology. Well, what do I mean by that? Well, hypertension in the absence of diabetes leads to insulin resistance. And it leads to insulin resistance probably by many factors and factors we don't even know, but some easy ones are with microvascular endothelial dysfunction, for instance, or vascular disease in skeletal muscle, for instance, rarefaction of blood vessels where you have marked decreased glucose delivery to skeletal muscle, obviously the primary utilizer of glucose. And thus you cannot dispose of glucose in the presence of hypertension and vascular disease, either in endothelial dysfunction or frank rarefaction. And that leads to insulin resistance, which then leads to new onset diabetes, now with the presence of hypertension. Well, let's flip the coin and go the other way. And that is, what happens with individuals with already the presence of diabetes? Well, that also contributes to an elevation in blood pressure. And that pathophysiology is also joined as the hip. Just as hypertension leads to insulin resistance and diabetes, diabetes leads to insulin resistance. It's already present as the primary modality. What does that do? Well, insulin resistance makes you resistant to insulin, and insulin is a very potent endogenous vasodilator. And thus, if you have tissue resistance to insulin and vasodilation, the blood pressure is going to further elevate, leading to hypertension. So it's puzzled me, having known the integration of the pathophysiology of these two diseases for so many decades, if the disease is actually smarter than us. The disease is already integrated. What we now need to do is catch up. And we need to catch up with integrating our care of our patients with diabetes and hypertension together, especially at the primary care level. And that is why I think it's so important to have this webinar today, to have the publications that were wonderfully published in the journal and in the symposium issue that we've been discussing. And again, the final common pathway of all of this, I think, is hearts. We've had great difficulty coming to the conclusion ourselves to integrate diabetes and hypertension care. Well, perhaps we need a tool. We need hearts to push that forward, to show us the way, if you will. Every component of hearts, every pillar, from HEARTS, is sentinel to the foundation of the management, approach, and prevention of both diabetes and hypertension. It's time now we catch up to the disease, and we catch up by integrating now the care of our patients with diabetes and hypertension. And soon, if not already, we will be talking about, and I've already mentioned, chronic kidney disease and hyperlipidemia. And with that, Pedro, I thank you for allowing me to share these closing thoughts with you today.
Wow, muchísimas gracias, muchísimas gracias. Yo decía
Thank you very much. I was saying to take this down because this is wise advice. Take down what Dr. Donald DiPet has said, that the disease has been more intelligent, smarter than us. And he's telling us to integrate our approach. And we've taken far too long to do what we should have done. And so instead of everyone approaching each disease in isolation, the clinical focus of heart is holds out much potential. The advice given to us by Dr. DiPet is the wisest advice with which to conclude this webinar. Thank you very much. I thank you for your courtesy and for your wise counsel, your wise advice for this public. So we have come to the end of the seminar. We have a full house. No one's left. I don't know how we did it, but I want to tell everyone who has taken part, the first 500 are going to receive a certificate of participation from the Pan American Health Organization. For your attendance, I would like to thank the audience we've had today from all of the countries. Next time, we'll have more time to highlight the different places people are joining us from. I would also like to thank those responsible for this quality webinar, the interpreters, the Hearts team, Jenny Rodriguez, who coordinated this effort. And I would like to close the webinar with a note that was written a bit back in the chat. Written by someone named Raquel. She didn't say what her last name was, but take a look at this. How I want to be a heart promoter among professionals and in the community. So Raquel, I hope that you can convince a lot of people to join you in your desire to become a promoter of heart in your community. So have a good afternoon. Thank you very much. And we conclude this webinar and the special issue of the Pan American Health Journal.
Hi, I'm Dr. Mark Jaffe. I've spent 25 years treating patients for hypertension at Kaiser Permanente, where we improved blood pressure control rates from 44% to 90% using a simple, practical treatment protocol. I want to share with you why it's so important to move from hypertension guidelines to simple hypertension protocols. The best protocols have specific drugs and specific doses, and they have a linear, one-step-at-a-time approach. Here's a great example from Punjab, India. It's easy to understand, and it has just 3 drugs. A simple protocol is best for blood pressure control for 3 reasons. First, it's just 1 page, so it's easy to train healthcare workers. Second, there are fewer medical errors when doctors and patients have simple instructions to follow. And third, a good protocol makes it a lot easier for pharmacies to forecast which drugs will be needed. It's also less expensive to buy larger quantities, fewer drugs. Each country or health system should pick a protocol that works for them. This is based on the drugs available in their country and the drugs that the doctors are comfortable using. Of course, when patients don't tolerate specific drugs in the protocol or who have side effects, they're managed differently and often by specialists. But most patients will be treated using a standard protocol. Now, the drugs selected should be low cost, and of course, they should always be safe and effective. The bottom line is that simple, practical treatment protocols have saved millions of lives already, and they can save millions more.